I'll introduce myself, Paula. It's fine. Yeah, I'm Binita Kane. I'm one of the respiratory consultants who, at the time of this project, was working at Wythenshawe Hospital. So I'm going to talk you through some of the kind of practical aspects of what we did. But I just wanted to start, really, before I launch into this, putting a bit more context around what Dee and Helen have already said. So when spirometry ground to a halt for a couple of years during the pandemic, that was an absolute disaster for patients. I mean, respiratory disease it's one of the biggest killers in Greater Manchester. And we, as respiratory physicians, we lost our diagnostic tool. That would be like cardiologists not being able to do ECGs or blood pressure monitoring. It was a complete disaster. And it turned out that primary care were never commissioned properly to do spirometry in the first place. It's just something they did on top of everything else, and the nurses sort of trained themselves up. So when it came to standing services back up, when it was safe to do so, primary care turned around and said, well, actually, we're not paid to do this. We haven't got funding for training staff. We haven't got equipment. It's kind of fair enough, really. So that led to a big project, both at national level and at ICB level, to try and commission services properly. But that was a long and arduous journey. And in parallel, the national team were looking at setting up these community diagnostic centres, or the CDCs that Dee has just talked about. So this is a different funding stream that was coming down to hospitals to create these hubs in the community that GPs could refer into, which would encompass spirometry. So all of these things were happening in parallel. But meanwhile, we had about 4 years where people couldn't get spirometry tests done. So when Matt and the team came to us and said, we've got this solution where we could potentially do this for people at home, we were like, wow, this could be an absolute game changer for the system if we can really do this well. So the project itself was a joint working agreement. So that was the kind of the contractual structure between Health Innovation Manchester, AstraZeneca as our industry partners who supplied the platform, the physiologists who were going to do the remote spirometry, the devices via a company called Nuovo Air. And our first pilot was really about testing that whole process out end to end. We've already heard about SNUC, who are this incredible organization who did this very in-depth patient experience and end user experience work, which is really quite fascinating for me as a clinician, how badly we generally do that stuff. So we called this first pilot Proof of Value 1, POV 1. And really that was about, is it feasible to do this? Like, can we really send these kits out to patients to do at home with a remote coach? As a clinician, am I absolutely sure that I trust this technology, that it's going to be similar to if I sent somebody to the hospital to have a proper lab lung function test? And also, what do we need to understand? I mean, logistically, this is huge, trying to deliver kits out to patients, get those returned. How does that operational side work? You're trying to coordinate physiologists and people at home and kit delivery. So we engaged the North Manchester Hospital respiratory team. So Jenny Hoyle's a consultant there, and her lung function lab said, yeah, we'll support this. And the knock-on effect of everything I was talking about before is that the hospital waiting list just got longer and longer and longer. And so they had these enormous waiting lists where people were waiting 6 months plus for basic spirometry. And, whether you're a patient who is just a little bit breathless and waiting to have your lung function sort of ruled out as normal, or whether you really got quite a serious lung condition, you're in that same queue with no triage. And that was actually costing lives due to delays in diagnostics. So they said, yeah, we'd love to help you with this. And so they said, we'll recruit the patients, we'll get them to do the spirometry at home, and then we'll invite them into the lung function lab, and they'll have a separate lung function test a few days later, and then you can compare whether we think this is accurate or not. And then the team there also provided insights to us about the project. in parallel to that, we also had to think about what does the second stage of the project look like. So we wanted to, and conceptually at the start of this project, roll this out in primary care, as Dee has talked about. And we wanted to put, prove it works in proof of value 1, and then do proof of value 2, where we put 1,000 patients through the remote spirometry test. And our targets were 50 patients for the first proof of value. So as Dee's talked about, there was also work going on through the business intelligence team where they were looking at, what's the demand in primary care networks? Can we look at whether primary care networks in deprived areas have got more demand in non-deprived areas? So we're doing all of those insights. And Dee and the team and Helen were also looking at how do we engage with primary care? Like, what does that communication look like? How are we going to persuade really busy people that they want to get on board with this, supporters? How are we going to train them, get them engaged? So all of that work was also going on in parallel. So getting into kind of the delivery of POV1, the North Manchester General team, there was 2 registrars who helped recruit the patients, and they targeted 54 patients and managed to persuade 24 to take part. Now, I really want to just pause for a second and say that this team did this on top of their usual NHS jobs. So it was slow and hard. And also they're trying to persuade patients that they want to do this whole additional step when they've also got their lung function just booked in. So we're asking patients to do something extra for nothing, really. So they did brilliantly because, they did absolutely brilliantly to get those patients recruited. And North Manchester patients, I don't know if anyone works at North, but, there's a very, very deprived cohort of patients. And so about as real world as it gets. So the pre-assembled kits were delivered to these 24 patients' homes. And then they had this coached video spirometry call. So they've set it up. There's a SIM, so they don't have to have internet access. There's 2 screens. So you've got one screen where you've got your remote physiologist, and you've got another screen here, which gives you some insight into how well you're blowing into the machine. And then you've got your handheld spirometer. So your physiologist is kind of deep breath in, blow hard, blow, 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 blow. The patient's got a visual so they can see whether they're doing it correctly. And then that's how the whole thing worked. And then that report then goes back to the referrer, who in this case was Jenny at North Manchester. And then Jenny and I were then able to compare that result to when they actually came into the hospital lung function lab and had a comparative test. And so the majority of patients did produce reliable and comparative tests. There were a few patients where there was a bit of incongruence between the hospital test and the remote spirometry test. And there was a whole load of work that went into sort of looking into that in more detail. So I won't go into it all now, but we did a lot of work. Well, when I say we, North Manchester team did a lot of work testing. The physiologists tested it out themselves. They even got more patients to come in to the hospital and do same-day comparative tests. And by the end of all of that, there was a software update involved. We were very happy that the remote spirometry was accurate to rule out any significant lung disease. Now, if there was an abnormal test, the pathway was still that they'd have to go and have a formal diagnostic test done. So it's really important to kind of, to really highlight that this, we're not saying that this was a definitive diagnostic test, but it was really helpful to rule out normal lung function and then prioritize the people who really do need to go to the hospital. So I think the main sort of headlines were that the patients really liked it. As we've already heard, they liked the fact it was flexible. They could do it at home if you're working. This is something that could take, half an hour, 40 minutes without all the faff of going to a hospital and parking and finding the lung function lab. Nearly 60% had normal lung function. And if you think about those enormous waiting lists in secondary care, if we could use technology like this to say that actually 50-60% of those people don't need to go, that really frees up that precious secondary care resource for the patients who really need it. So it's a big win for the system. There were some challenges, and I think this is so important that why this kind of proof of value work is important, because there's some things that we just could never have predicted. For example, turns out people don't really know their height. So if you're reporting your height to a physiologist and they're plugging it into the machine, and then the predicted values are based on that, and you've got your height wrong, that creates a diagnostic error potentially. So we only picked this up because then when the patients went to the hospital, they measured them properly, and I think the biggest discrepancy was 12 centimeters. So it's like, really not as tall as you think. Yeah. So then if you're going to then scale this up to 1,000 more people, you got to really think about, well, how are you going to get them to measure their height accurately at home? And that actually is not an easy thing to solve. So these little things, this is why these proof of value studies are so important. Talked a little about the QC gaps, quality control issues and technique issues, and that was all ironed out. But if we had just launched into scaling this up to 1,000 people without doing all of that, we might have got, some inaccurate results. So that was really important work. And then the pivot that Dee has talked about was really because at the outset we had thought this was going to be something that we wanted to embed into primary care. But with innovation, you always have to be aware that everything around you is changing all the time, the political landscape, commissioning landscape. So as the community diagnostic hubs developed during the program, it became obvious to us that this is who we need to be working with, not trying to roll it out to 70 different practices. So it did change, but I think that's an important part of innovation, is really keeping an eye on all of that landscape and being able to adapt your project appropriately. So this last box is just another kind of nod to, in the blue at the bottom, it's just another nod to the fact, if you want a gold standard diagnostic test, then you do have to do this thing called reversibility, where you do the blowing test, you give them a couple of squirts of Ventolin, and then you redo the blowing test, and you make sure you've got this sort of post airway opening measurement. And we couldn't do that at home just because it involved administering a drug, which brings in, even though you could just ask the patient in theory to take a couple of puffs of a Ventolin, that doesn't seem like a big deal. But actually, when you're bringing in pharmacy pathways and drug quality control and dispensing, and all, it creates another massive headache. So that is something that potentially could be looked at in future to be done at home, but right now we couldn't do it. This was slightly outside of the scope of the project, but it's just to say that we did think about if this sort of remote spirometry test was being sent back to a GP in primary care, how do we then guide them in the and so what bit? What do you do with that result? Because not everybody is skilled in interpreting these tests. So we are very lucky in Manchester. We've got one of the world's leading COPD professors, Professor Dave Singh, and we've also got Professor Steve Fowler, who led the latest NICE and BTS guidelines in asthma. So I strong-armed them into helping us create an algorithm that could be shared with GPs. So once they got the result, they could look at the algorithm and that will help them with the diagnostic pathway. The bit we've not been able to do as part of this project in the and so what piece is how would that then influence what happens with prescribing and diagnostics and capture those clinical outcomes, which hopefully will reduce in improved outcomes for the patients. How am I doing for time? Okay. So the patient piece was really interesting. So this company Snook, that AZ brought in, did the insights, and honestly, the process was amazing what they did. They mapped out every single bit of the patient pathway, thought really, really hard about what the points were where things could fail or things could be difficult. They did the sort of workshop with the patients, with the practical, opening up the packet and putting things together. They interviewed people, they interviewed the patients, they interviewed the physiologists, and they got lots and lots of insights. So if we were to roll this out for 1,000 patients, we could use all of that to kind of set it up not to fail, because we've predicted what the issues are going to be. So I won't go through all of this, but some of it may seem fairly obvious, but it was good to get these insights kind of written down and done properly, which is around that clear, accessible information from the GP in the service, which you'd think that would be a given, but actually, if you think about the level of information you often get from your GP practice, it's not very detailed, or a lot of thought often hasn't gone into it. Booking systems, how people wanted that to work. Some people felt the kit was very bulky and the instructions weren't kind of good enough in a way. Accessibility, so if you've got sight or hearing impairment, how is this going to work for you? What adaptations do we need to make for those patients? Having some support, actually, some technical support, not just in doing the procedure, but in setting things up. And yeah, there was lots and lots of things which would then feed into that sort of second proof of value study. This is not, I should not have been given this slide to present, so I apologise if I make it. This is all about the project management and delivery side of things. So really, Daniel or one of these guys should have done it. It's all speak I don't really understand. But there was lots and lots of stuff that we learned about how you coordinate all of those moving parts. How do you run a project where you've got 10 different stakeholders all doing different things? And some of what Dee talked about around those kind of meetings and those scrums and tracking risks and issues. These enormous spreadsheets that I didn't really understand. But from a quality and safety perspective, it's really thinking about how do you do that quality assurance? How do you make sure that every single spirometry test that you send out to a patient is quality controlled and checked and is going to give you an accurate result? And there's all sorts of stuff around data transfer and how data moves between different people as well. And there was a few bits and pieces as well about the training. So we got some insights from POV1 about how you actually coach people to do the test and some really important things that are not going to get in the way of an accurate result. So how do you deliver that training consistently to the physiologists who are going to do this test? It's like, there's a lot to think about.